Our study looked at 71,000 children under 18 and assessed how long they fast from clear liquids before surgery. We wanted to define this in two parameters. First, the median fasting duration, and second, the proportion of children who are fasted for much longer than the American Society of Anesthesiologists recommends. The ASA, the society, recommends fasting for 2 hours, so we considered prolonged liquid fasting as fasting for over 4 hours. Our results showed that children in the entire data set were fasted for a median of 10.3 hours, and children under one, those infants and neonates, were fasted for 6.4 hours. When we looked at the proportion of children in our data set who were fasted for over 4 hours, so for over twice the American Society's guidelines, we found that 79% of children in our data set were fasted for over 4 hours, with a large proportion fasted for longer than 10 hours.
The preoperative fasting as an intervention to prevent pulmonary aspiration has really never been properly assessed for its efficacy, its ability to reduce the risk of aspiration, and its safety, the side effects of fasting. And the clinical challenge here is that the guidelines are made based on expert opinions and extrapolations from physiological experiments. While both efficacy is highly physiologically plausible, but harm from fasting, particularly prolonged fasting, is also highly physiologically plausible through dehydration and deprivation of calories. And there's now mounting data that the harms from excessive fasting are meaningful to the point where many countries worldwide are either reducing preoperative fasting requirements, as for example in the guidelines by the European Society of Anesthesiology and Intensive Care, or trying to abolish the requirement for preoperative clear liquid fasting in children or in adults. And one point of reference here is the Eurofast study. The problem with both the guidelines and the latter study is the relative lack of data. So we're trying to make decisions based on an educated guess and low-level data. And our study tries to address this paucity of data by quantifying the duration of fasting so that we can take the next step and start quantifying the effects of this prolonged fasting. I can take this one. Uh, I think there's a reason why guidelines exist. We, as clinicians, we often outsource the need to plow through the literature, try to figure out what's the best thing to do to committees of people who dedicate months, sometimes years, to assess the evidence and come up with reasonable, practical recommendations. So from that perspective, it makes sense to follow the guidelines and perhaps focus on the implementation of guidelines. One approach to facilitate guideline implementation that is gaining popularity worldwide is protocolization. So having local protocols, local institutional guidelines that are developed through interdisciplinary collaboration, which ensure that the surgical teams, the perioperative nursing staff, the anesthesiologists all agree to adhere to the current recommendations and work towards implementing these recommendations, which is currently the missing link. The recommendations suggest that children should receive clear liquids until 2 hours preoperatively. But this doesn't happen. That's what our findings suggest. We see that children fast for 3 to 4 times longer on average than recommended, and this is likely harmful. And that's exactly what current guidelines state. So it makes sense from my perspective for the hospital teams to get together, try to think how in their workflow they can minimize this unnecessary fasting that likely leads to dehydration and calorie deprivation that are not necessary and potentially harmful.
I think the key takeaways for me is this study shows real world fasting data in children. The study shows that children are fasted for much longer than the American Society recommends. And these numbers represent a large number of children in our study. Over 40,000 children were fasted for over 4 hours. And extrapolating that data, there are likely many, many children nationally who are fasted for much longer than recommended. This is very important as this is a great area of active research and more work needs to be done, both in understanding the data behind the harms of fasting, behind what safe fasting is, and then finally what we as clinicians can do to mitigate some of the effects of prolonged fasting. Dr. Nagrebetsky, do you have things to add?
Yeah, I guess to add to that, that if if the scale of excessive preoperative fasting is truly as our study shows it is, and if the harms of this excessive fasting are what we think they are and what the preliminary data shows they are, then this problem is of public health proportions, since millions of children undergoing elective surgeries in the United States alone are likely exposed to this unnecessary and likely harmful clinical practice.